I'm a data science core with South Carolina INBRE, myself and Dr. Zhang. We could not be here for health reasons today, but I'll be leading this session, and it's the first of our seminar series. We're hopeful to have four each semester, and also then have a hands-on workshop in the summer. So we really want to hear from you guys what you would like to hear, what you'd like to see. If you want to follow up, we're here to serve you. So we're looking forward to seeing you all at the symposium. But today it's my pleasure to introduce our speaker, Dr. Yuhao Kang. He directs the GISense Lab at the University of Texas, Austin. The lab focuses on human-centered geospatial AI and GIS to understand human-environment relationships and address real-world challenges. He has worked leveraging large language models to support coding in maternal health, the topic he's going to talk about today. He's currently developing a cutting-edge reinforcement learning to support maternal health resource allocation and inform policy. He's also measuring maternal care accessibility to help identify underserved regions. He was previously at the University of Minnesota, worked at Google X, MIT Senseable City Lab. He earned his doctorate from the University of Wisconsin-Madison. He was the recipient of the Waldo Tobler Young Researcher Award by the Austrian Academy of Sciences, the KGIS Rising Award, the CPGIS Educational Excellence Award, and so much. And today he's speaking to us actually from Sweden. So, Dr. Kang, I was turned over to you. Welcome.
Yeah, thank you, Banky. It's really my great pleasure to join this seminar and to share some of my past, recent, and ongoing work to empower maternal health with AI using large language models for coding and reinforcement learning for resource allocation. So actually, we started such kind of projects to using AI to empower maternal health because I previously worked at the University of South Carolina, and it was my great honor to work with a few health professionals. I know some of you are also here today, and for this project. Not only myself, but I have some key co-authors such as Dr. Shan Qiao, Dr. Ran Zhang, Dr. Han Qi, Andy, Dr. Fahui Wang, and Dr. Pei Yinhong, as well as Dr. Mi Xiao Li. Now let's move forward to talk about how AI. We know that we are now living in the era of generative AI, like how AI may empower different health professionals to accelerate or even facilitate some of the health tasks. I'm sure that all of you may have tried some different types of generative AI, such as ChatGPT, Gemini, or even Cloudy. For instance, now with ChatGPT, it can even communicate with people. You can chat with it. You can leverage this to help you like writing. For instance, I cannot leave it ChatGPT now, especially for me as a non-native speaker, I always leverage ChatGPT to help me to proofread my manuscripts, all of my documents. Um, so that is just one thing. And actually, generative AI is a broad umbrella. The most notable tools refers to ChatGPT, refers to Gemini. They are kind of what we so-called text-to-text models or large language models. But at the same time, there are some other generative AI algorithms. You may have heard about DALL-E, heard about Stable Diffusion, Midjourney. So they are text-to-image model, or what we so-called the diffusion-based models. Compared with ChatGPT, ChatGPT is good at for text. It's good at for handling text. But for text to image models, they are good at for creating graphs. And these two are just two examples. But there are some other algorithms. For instance, the reinforcement learning, which is another type of cutting edge algorithms supporting for the reasoning. Yeah, supporting even for the reasoning. Another powerful algorithm. So today, as you know, I would like to not only to focus on to showcase some of the advanced AI, but I want to emphasize how generative AI may empower the maternal health professionals, may help solve some of the maternal health challenges. So my work, as Banky just introduced, I work on geospatial AI and big data, in particular to utilize geographic knowledge and AI approaches to extract meaningful insights from large-scale spatial or geographic data, including geospatial big data as well as GeoAI. So I focus on different domains. Now, one of my major focus is the maternal health. Maternal health. Because now we are living in the era of AI. It seems that AI is indeed a very popular topic recent, like in the news or even like when you prepare some of the documents, you may always like preparing for the funding, you may always hearing about AI. So in this case, can we empower maternal health with AI? Can we empower maternal health with AI? So today I would like to introduce two products. One is using large language models for qualitative coding, and the other is reinforcement learning for resource allocation. So when we talk about coding, when we talk about qualitative coding, when doctors, when health professionals diagnosing patients, we may need to collect some interview survey, conduct some interview to get some survey, and then we need to have the manual coding to extract the necessary and key information from the patients, right? So coding and qualitative coding is indeed a very important um, process in or common practice in health-related studies. To conduct the coding, it requires professional knowledge, and it's usually time-consuming and labor-intensive, and it might be influenced by personal biases. I assume some of the audience in this seminar also had been practicing, like have been using qualitative coding to extract the information, either from those interview, from those survey, or conducting literature review, right? But for me, it's a bit challenging for me to do so because I don't have such kind of maternal health professional knowledge, and also to finish to generate high quality of coding, we need to recruit some people. We probably not only one person but multiple person to finish the coding, the complicated uh, coding process. And also, different people may have different personal bias. For two people who are conducting the coding for the same documents, the two people may have different insights when extracting the insights, right? So in this case, we are curious about whether large language models may offer some new opportunities to extract the key information to reduce the manual translation and also to improve the efficiency of the workflow. So in this case, we were one of the very first efforts to explore how large language models could be used for in-house domains for qualitative coding. So we leverage ChatGPT because, as you know, ChatGPT or large language model, although it's a chatbot, right? It can understand language and even context, and it can even have some deeper exploration of implicit information that is not explicit in the sentences or paragraphs. And it can has the capabilities to even summarize some key information from those contexts. So in this case, our study previously published on the applied psychology, health, and well-being, we propose a coding framework for public health interview transcripts by integrating ChatGPT. So to build this computational framework, we leverage an existing experiment to integrate LLMs for coding. There was a qualitative study on health disparities of maternal health services and outcomes during the COVID-19 pandemic in South Carolina, which was conducted by my collaborators, Dr. Ran Zhang and Dr. Shan Qiao. They recruited 19 Black and 20 Hispanic women from 9 maternal care providers, and they conduct a survey and ask them. They conduct the interview and ask them a few questions such as what are the challenges providing maternal care? Are there any differences in labor and delivery in your facilities during the COVID-19 compared with pre-pandemic, etc.? So then in this case, we take this as an example and explore whether large language models or ChatGPT could support the qualitative coding process. So we first analyze or we first analyze or review the common practice in qualitative coding. Generally speaking, there are two types of questions. And then for these two different types of questions, we develop different process. The first one refers to the theme summarization for questions with unknown categories. This is one of the most important and widely used process like in qualitative coding. In other words, assume we have some interview transcripts. We want to automatically extract and summarize the themes of responses the providers gave to the question from the interview transcripts. For instance, the example question might be, what is the challenge? What is the challenge? And we can leverage ChatGPT to automatically extract and summarize those different themes based on the patient's interviews transcripts. We can extract themes such as visitor restrictions, telehealth limitations, inconsistent care standards, etc. The second type of question refers to theme classification for questions with known categories. Sometimes when we run the qualitative coding process, we may already know what's the questions, or we may already know what's the event of interest. And we want to identify those sentences or those transcripts associated with which class do they belong to. So given the event category of interest, each dialogue of the provider in the transcript is automatically classified so that the researcher can obtain the dialogues that talk about the event of interest and further check the details. For instance, we may already know that we want to identify those sentences related to visitor restrictions, related to health limitation, telehealth limitations, inconsistent care, etc. Then in this case, we explore whether large language models may help to facilitate this process.
这啥软件啊？
So for the first one, questions with unknown categories. Uh, well, we develop this four-stage process starting from data pre-processing, question positioning, theme extraction, and finally manual filtering. So the first step refers to data pre-processing because when we collect the transcripts, the first step is we need to process them in a format that is easy for machines to read or easy to be fed into the large language models. For instance, as you can see, the dialogues may look like this, like interview, provider, interview, and then provider. We have the interview transcript, and we first translate this and organize this into a transcript table in a CSV folder, in a CSV file. As you can see, we have the ID, we have the interview questions, interviewers, and also the answers from the provider. By organizing this, we can further, by formatting and organizing the transcript, we can further input them into the ChatGPT. After that, we first have another pre-processing or filtering because in the transcripts there are a lot of sentences not associated to the questions that we want to ask. So the next step is filtering unnecessary information and to identify those questions and answers that we need. So if there is a dialogue asking the question, for instance, what is the challenge? Like this is a challenge, so keep the sentence. By positioning this and identifying those sentences in the transcript, we can filter out and only focus on those transcripts related to the questions. So the next step refers to the sim extraction. After we filtering and pre-processing the data set, the remaining sentences are all containing important information related to the questions. So we further extract the semantic themes of these transcripts. Like, can you help me extract the topics from the response about the question, such as what is the challenge? And then ChatGPT or large language models are now capable to extract several themes, such as vaccination hesitancy, visitor restrictions, and telehealth limitations, etc. So our study was conducted in about 2 years before. At that time, ChatGPT 4.0 was one of the most advanced algorithm at that time. But now, there are more and more advanced algorithms like ChatGPT 5.2, Gemini 3.0, or even and other like Cloudy Code, etc. They are more and more advanced, and they can extract the theme in a more accurate way. But we believe the general idea or the general steps are still similar. And after ChatGPT extracts these themes, the next step is we still need to have the manual filtering to manually check whether those themes make sense or are valid. So it is still necessary to have human in the loop to evaluate the themes extracted by ChatGPT. So that's for the first type of question. Like we start from data pre-processing, question positioning to filter out those unnecessary transcripts and only focus on those transcripts related to our questions to extract the themes. And finally, we have human in the loop. We ask people to still manually review those themes extracted by generative AI to assess whether they are correct or they make sense or not. Well, for the second one, the second type of question, same classification for questions with known categories. We follow a similar process. Like we first start from the data pre-processing, and after that, we have another round of filtering because, as I mentioned, a lot of the transcripts may not necessarily related to our questions. So we ask it to iterate each response and identify if the sentence is related to the question to filter out. After that, we can then classify each text based on our given topics of based on the given topics of the sentences. So as I previously mentioned, we take this example, the qualitative study on health disparities of maternal health services and outcomes during the COVID-19 pandemic in South Carolina as an example. And here are some of the results. For instance, we ask, for the question, what are the challenges providing maternal care? ChatGPT and large language models can, after reading and reviewing all of the transcripts, here are the topics extracted. And for the other question, like what have made them stressed and anxious, would you like to share any examples? ChatGPT also extracted the following themes. It should be noticed that when we ask ChatGPT to summarize these themes, there might be some duplicated categories. But because we have human in the loop validation, we ask a human to help us assess whether these generated categories make sense or not, and also assess the accuracy. We notice that in 2 years, ChatGPT has generated 193 categories, and the overall accuracy reaches around 90%. Yeah, reaches around 90%. So to summarize, in this paper, we propose a coding framework for public health interview transcripts using ChatGPT. And we specifically focus on two types of questions. One is the same class summarization for questions with unknown categories. For instance, we don't know what are the information, what are the themes that we would like to extract. Then we leverage large language models to support this. And the other one is theme classification for questions with known categories, because sometimes we already know the theme classifications, but we want to identify those sentences related to each different categories. So we notice that ChatGPT also perform pretty well in both tasks. So to summarize, we propose a novel coding framework for public health interview transcripts using ChatGPT, and generative AI shows promise in accelerating quantitative coding process and may benefit a variety of maternal health tasks. But it is still crucial to have human in the loop and integrate more domain knowledge when using generative AI to avoid potential risks. Because you may have also heard about that ChatGPT or generative AI may have hallucination issues. In other words, may generate some fake information. It might be sensitive, especially if we leverage ChatGPT on some health data. So then in this case, we need to validate human in the loop. We still need some health professionals to better refine and improve the AI generated results. But if we can combine, for instance, if we can integrate generative AI first to help you to generate a set of um, preliminary results, preliminary coding results, it could definitely help and automate the process and to facilitate the entire workflow. Yeah. So that's my first project. To summarize, this paper, the experiments were conducted in 2 years before, but as you know, generative AI is evolving so fast. So I'm sure if you try ChatGPT now, the results, the performance will be significantly improved. But even if it can it significantly improved, but we still think human or domain knowledge are necessary to ensure and to validate the results and to ensure it do not generate some potential risks. As I previously mentioned, that large language model is just one of the most popular one, but there are some other types of generative AI. Yeah, generative AI. So now let's move to the second project. Another type of method is called reinforcement learning, which we envision it could support the resource allocation to inform maternal health policy. We all know that in maternal health, or generally speaking, for the public health, there exist significant inequalities in healthcare accessibility. Yeah, so across the United States, the access to healthcare facilities vary significantly. For instance, in urban areas, residents might be easier to get access to certain health facilities, while for residents living in rural areas, it's challenging for them to get access to health facilities. And in maternal health, we also observe similar health disparities. So this is another project. We term this as equitable motherhood, specifically focusing on maternity care. Residents in rural counties experience much higher mortality rates compared to their urban counterpart. So can we reduce disparity in access to improve maternity care and enhance equitable motherhood? Can we do so? So how can we reduce the disparity in access to improve maternity care and enhance equitable motherhood so that mothers in different regions, they can still get sufficient support in maternity care? So this is a collaborative work with several researchers such as Dr. Pei Hong and Dr. Fahui Wang, as well as my own team. So our solution is actually pretty intuitive. We first want to identify regions that need additional healthcare resources And then we probably can reallocate healthcare resources using a cutting-edge AI methods supported by reinforcement learning. So the idea is very intuitive. Let me show you this example. Assume we have three hospitals. And these two hospitals, they have sufficient healthcare resources, such as they have enough doctors, they have enough beds. But at the same time, there might be another hospital with only limited healthcare resources, very limited healthcare resources, like only 20. Then in this case, how can we optimize the healthcare resources? How can we enhance the inequality? How can we enhance the equality? Our idea is it possible that we reallocate some of the healthcare resources from those resourceful regions to those underserved regions? Like we can move some healthcare resources from this hospital to here, and then from this hospital to here, so that it can enhance this hospital located in the underserved regions. Although I mentioned that the healthcare resource, but I didn't specify what is healthcare resource because it can be any healthcare resources like number of professionals, number of doctors, number of beds, number of ICUs, or vaccines during the COVID-19. So if we follow this solution, then we probably can enhance the accessibility for all. Like for this hospital, residents nearby could also enhance their accessibility to hospitals because they can get access to some hospitals with more resources. So how can we do so? Another AI method is called reinforcement learning. I'm not sure how many of you have heard about the AlphaGo. Go is a popular game similar to chess. And back to 2014, it was the first time AI beat human world championship in Go, and that algorithm is called AlphaGo, developed by Google DeepMind. And AlphaGo, its underlying mechanism is called reinforcement learning, which is a type of AI where an agent learns to make decisions by interacting with its environment and receiving feedback based on the outcomes of those decisions. So let's take another example. Look at this image. Assume at the beginning we have two hospitals. One hospital has a lot of healthcare resources so that it can serve its mothers nearby. And another hospital only has very limited resources. So that's why even a mother nearby its hospital still visits the other hospital. So is it possible that we can even reallocate the workforce or reallocate some other healthcare resources? Here, I take the workforce as an example, but it's not necessarily to restrict it to workforce. We can also reallocate other healthcare resources, such as we can reallocate number of beds, we can reallocate funding, we can reallocate scholarship opportunities. Then in this case, like we can reallocate some healthcare resources so that this hospital could receive more healthcare resources and can serve more mothers living in those underserved regions. But how can we do so? Then we can leverage this reinforcement learning. The reinforcement learning has three components or two primary components, that is the environment and agent. The environment here is the spatial distribution of maternity care systems. We can compute this based on the maternity accessibility and healthcare resources. For instance, we know like what for each neighborhood, what's the accessibility to certain hospitals, and we also know what are the healthcare resource distributions. So that's the environment. And then we can have another agent which can reallocate healthcare resources from resourceful regions to underserved regions. And each adjustment involves transferring only a limited amount of healthcare resources. For instance, like we can reallocate one unit of healthcare resource. Again, the healthcare resource could be workforce, could be doctors, could be funding, could be scholarship opportunities, could be number of beds, could be those facilities, any forms of healthcare resources. We can reallocate those healthcare resources, this agent, and then we see if the environment improves or decrease, improves or not improve. And if it improves, then the agent will keep reallocating the healthcare resources. And to achieve this, we need to define an objective, which refers to the reduction in the overall variance of accessibility to maternity care facilities, because we want the healthcare resources more evenly distributed across the space. So that's why we reduce the overall variance, to reduce the overall variance of accessibility to maternity care facilities. But at the same time, we can actually also develop another objective to enhance the overall accessibility to maternity care facilities. So this was just a conceptual framework. So later we take the example in Florida as an experiment. We created based on the data sets around 1.5 million birth certificates in Florida from 2016 to 2020, including the number of obstetric professionals and beds in hospitals. Then we first measure the accessibility. Yeah, we first measure the accessibility based on the commuting patterns. So this is a recently published paper published on Health and Place, led by my student Hanqi Li. We developed a 2SFCA, a two-step floating catchment area accessibility index using this real-world birth delivery data at both zip code level as well as county level. As you can see, we can identify a few regions with low accessibility and some other zip code regions with high accessibility index. And as you can see, generally speaking, regions in large metropolitan areas, residents have higher accessibility. And after that, we take this as an example to use reinforcement learning to optimize the accessibility. As you can see, we can easily identify and observe the disparity patterns in accessibility, right? Some regions have more accessibility. Some other regions, especially in rural areas, they have limited accessibility. So our idea is we want to reallocate some of the healthcare resources from resourceful regions to underserved regions. So here is the environment. As I mentioned, the reinforcement learning need environment and action. The environment is those supply nodes, such as the hospitals, number of obstetric beds, or number of obstetric doctors, and the demand nodes, like the counties and the accessibility scores. We can define several actions, and including some restrictions. For instance, the hospitals can never fall below 50% of their original obstetric supply, because for instance, we can reallocate one hospital from one region to another region, then it may enhance the overall accessibility. But in real world, it's infeasible. I don't feel hospitals are happy to lose all of their doctors. Then in this case, we can easily implement some of the real-world restrictions in the action. For instance, we can say hospitals can never fall below 50% of their original obstetric supply. But this is just a number. We can also adjust this to 80% or 90%. And here are the objectives. We want to decrease the accessibility variance, and we want to increase the overall average accessibility. So on the one hand, we want to decrease accessibility variance to enhance the equality and to reduce the geographic disparity in accessibility. At the same time, we hope overall the average accessibility across the entire study area in Florida could be increased. So we take these two objects into our consideration in our reinforcement learning. And we also design 3 real-world scenarios, including minimizing the distance, such as transfers should be as short as possible to reduce the distance cost. Because, for instance, if you assume a doctor work in Colombia, it's possible that the doctor may reallocate to nearby cities such as like KC. But if you are a doctor living in Colombia, you probably do not want to be reallocated to New York. That's too far away. And a second scenario is, as I mentioned, we can preserve resources, like the resource allocations should not take away more than 20% of a hospital supplies in one transfer. And finally, we can targeting underserved regions. We can say we prioritize certain communities, such as those low-income counties. When we reallocate the resources, we should prioritize certain communities. So here are the results compared with the basic one. Like we do not have any restrictions. Our scenario 1 can reduce the distance. And the second scenario result, as you can see, so all the hospitals, when we reallocate healthcare resources, they will not lose over 50%, or yeah, depending on the threshold you determine. Here we determine 50%. Like in other words, the healthcare resources will not be taken for 50%. And we can also target specific underserved regions. Baker, Cuyahoga, and Holmes County. These 3 counties have relatively low incomes in the entire South Carolina. So we target these 3 counties to give them additional healthcare resources. And as you can see, so this our model in the green one can target the underserved regions. In other words, these underserved regions will receive additional healthcare resources compared with other counties in Florida. It's not in South Carolina because our study area is in Florida. And here are the final simulation results. As you can see, if we have the 3 scenarios and compare with this is the original one, like the current accessibility, and we compare with the statistical based QP method and a basic one without any restrictions. We also develop the 3 scenarios, and then we develop a combined one that considers all of these 3 restrictions. And as you can see, generally speaking, the weighted accessibility variance decreased from 4.32 to around 2 point, no more than 3, In other words, if we leverage our algorithms, the entire accessibility, we can reduce the disparity in accessibility. Across the entire study area. And the average accessibility will at the similar stage. Because in this model we prioritize weighted accessibility variance. We want to reduce the disparity, but we can also change the algorithm objective to increase the entire accessibility, the entire overall average accessibility. So as you can see, although we only demonstrate 3 scenarios, but this algorithm could simulate what-if scenarios on changes in maternity healthcare resources. For instance, we can also develop another scenario like considering all of these restrictions and even consider some other restrictions, and then we say we hope the variance reduce and also average accessibility increase to a certain degree. So by combining these 2 together, we can simulate what-if scenarios which support the policy decision making. For instance, we can deliver a final code book to show if you set the following environments with the following restrictions, what the results looks like, what regions they may reduce their healthcare resources, and what regions they may increase their healthcare resources. Yeah, they may increase their healthcare resources. So we believe our algorithm could simulate the what if scenarios, and then it may benefit the real world policy implementation. So to conclude, in this work, we demonstrate that reinforcement learning provides novel solutions for reducing the inequality of access to maternal health care facilities. And it is necessary to conduct a multidisciplinary research to translate AI to really benefit real-world practices. The reason is that although AI is pretty advanced, it is evolving fast, but there is a gap between the technology and the real-world practice. So this is also another experience when I collaborating with my collaborators in health domain. Sometimes we feel that even though AI is cutting edge, but the real world practices have also have a lot of variables. So it's challenging to encode those restrictions into the AI. And more domain knowledge in public health and policy are still needed to guide the development of AI, because because currently the AI is developed for general domains, but if we want the AI can really be implemented for a specific domain like maternity care, maternal health, domain knowledge are still necessary. And also in different domains, in different healthcare domains, the knowledge might be different. Like for maternity care, the setting is this, but in another domain, the healthcare, the distribution, the environment, and the agent might be different. So looking forward, I believe AI indeed brings novel opportunities to empower the maternity health practices, and collaborations and conversations between AI scientists and health professionals are crucial. On the one hand, I do wish more health professionals are open for AI, because I truly believe AI can benefit some of the real world challenges. And on the other hand, I also feel AI scientists should have more conversations with health professionals, because the technology, even if it's cutting edge, there is a gap to implement that into the real world practice. It's still necessary to understand how AI works in the real world settings. And finally, human in the loop and domain knowledge are necessary to guide the development of AI. For instance, back to my first project, using ChatGPT to support qualitative coding, we still need human to finally review the extracted themes. And at the same time, for the second one, reinforcement learning, it is necessary to have more domain knowledge to guide the development of AI to better tailor to the real world settings. Okay, I think that's all for my presentation today, and it's truly my great pleasure to work with my collaborators. To be honest, 2 years before, I had very limited knowledge about maternity care, but so far we have already published a few papers in computer science, in health, and we see there is a promising direction to see how AI could really benefit the maternity care practice. Yeah, that's my presentation. Yeah, thank you.
Thank you so much, Dr. Kang. That was phenomenal. And before I open it to questions from the audience and also read them from the chat, just to summarize and give you the context, that the point here is whether you're a genomist or you're someone who does protein chemistry or you're a biochemist or you're a biologist, you are the domain expert there. The technology exists right now that you can leverage to do very creative and innovative things and do things faster, quicker, better. and there were keywords that he mentioned there that were kind of important: multidisciplinary team, relying on the domain expertise. And so the world is open for us, and really that's one of the things that we are trying to bring to you all, from the data science core, to get you into the conversation or into the mindset of thinking about this. So thank you so much for this presentation. I'll turn it to the audience for questions. And please, if you think your question is naive or not, there's no naive or not smart question here. Feel free to ask your questions. Everyone can learn. So I'll pause and let anybody who wants to ask a question before I read the one from the chat. Anyone? You can unmute and just start talking. Okay, while people are thinking, Dr. Hung had to leave, I think, or she had this very interesting questions about the first project. How did you operationalize thematic accuracy in this context? All right. And I think that has to do with when you're coming up with themes, you don't know what the themes are. So while AI could come up with the themes, how do we know the themes were correct? Or how do you use, what are the checks to make sure that it's correct? And then two, in your experience, was the minimum number of human experts required to establish strong inter-rater reliability? We can take those two first and come to the other two.
Okay, thank you, Dr. Hong, for your question. The first one is we tested different methods. We first ask people to assess whether they think they make sense. They make sense. Like the ChatGPT generated 193 categories. We ask people to assess whether they make sense to them. And also we ask people to manually coding as well. And then we compare the people generated the coding, the manually generated coding, whether it's similar to the ChatGPT generated coding. And we conduct two validation methods. First, people manually validate the two set of coding, like the people like generated some coding, and then they compare whether they generated the generated coding is similar to the ChatGPT. And also we calculated some semantic measurements to measure whether these two sets of responses are similar to each other. So that's how we measure the accuracy in this context. And for the second one, what's the minimum number of human experts required to establish strong inter-rater reliability? To be honest, I'm also not sure. I'm not that familiar with the qualitative coding process. But in our experiments, we have two human experts to code the same documents, same transcripts. Yeah.
Thank you. And then just to follow up on the transcript piece, how many transcripts did your human reviewers need to review to get the good reliability check? And then which of the coding process was most resource intensive? So to make sure that you didn't miss anything. Was it the machine-based process oversight or the interreliability or setting all of these things up?
Yeah, so for the third question, how many transcripts needed to be reviewed? So at least in our experiments, we have two people reviewing all the transcripts for coding. So that's our experiment. Well, for the last question, which part of the coding process did you find most resource intensive? I think there are two steps. One is the first to build the workflow. For instance, you probably need to build the first workflow to ensure one transcript can be successfully coded. After that, because we use coding, here the coding means programming, because we write the code, it can automatically it can automatically help you review all of those information to generate the semantic coding. So I feel to build the first pipeline is a bit resource intensive. And another resource intensive is the final review process because it is still necessary to have human in the loop to evaluate the themes extracted by ChatGPT. So this one also still takes some time or human labors to finish this step. I think these two are the most time consuming or resource intensive, yeah, and resource intensive stages.
Thank you. Um, I'll ask another question. If you're shy about asking questions, I hope by asking my questions and reading from the chat gives you confidence to ask again. Please ask. We have a few more minutes before, and since we have him here, this is great. Oh, that's a great question that just came here. Let me. Where did that go? Where did my chat go? Come back here. So in the chat, there was a question about where did the chat go? I lost the chat. I'll
Okay.
come back to the chat. I was gonna ask you, and it might go with the chat. I'll read the chat once I find it. But reinforcement learning is notorious for needing a lot of data points because it's not like supervised learning, right? To be able to learn, especially with the agents and things like that. With the kind of resource allocations that you're using, that you use in the study, how did you get over that? Because you have this finite number of hospitals, this finite number of resources. They are very specific. You have 400, 200 doctors here in a large health system, or this or that. What did you use to, and how quickly was your reinforcement learning able to learn with your agents?
Okay, yeah, the question, if I understand the question correctly, so your question is how long does it take to find the solution or to generate the solution, right?
Yeah, because it's always like learning through trial and error, right? And so it needs a lot of interactions to converge. But if
Yes.
your starting sample size is not large, are you simulating? Are you boosting? What makes
Yeah,
it go?
yeah, that's a very good point. So it depends. I think one I think one good thing for reinforcement learning is it actually doesn't need a lot of data points. Um, so it is pretty flexible as long as a few data points like this. Or for instance, in Florida, we actually only have a few, I think 100 counties. Then that's enough. It can already run the model. Uh, but regarding how many time, it also depends because um, um, it doesn't necessarily to be converged. It doesn't necessarily to converge. It can run several steps and then you pause and see how it goes. But in our experiments, yes, it takes a little bit longer time because we indeed generate some of the final results like this. Yeah, it takes some longer time. But for instance, if you don't want to 2.8, like just a 4, just a 3.5, it should be much faster. And you can set when to stop. I think that's one that is actually one advantage because you don't need it's not necessary to say we must need to have the optimized one, the global optimized one. Yeah.
Okay, awesome. I have other questions here. I'll read them. There's one says, are all the 100% transcript required, or could we reduce it to 80% or even 50% random responses? And what would be the implications for the generative AI if it was just random transcripts that were used rather than the full transcript?
Yeah, yes, that's a very good question. So I think we don't need uh I'm a little bit confused. Like, what do you mean by the
So
100%
I
transcript?
think what Dr. Ung is saying is, let's say we have 100 transcripts, and from those 100 transcripts, you came up with these themes. You came up with this 3 or 4 themes. Let's say we reduce the transcripts to 50 randomly. Oh, Dr. Ung is there. Maybe if I don't say it correct, let me know. and would we still get the same themes, or again, that's going back to the accuracy of the generative AI in being consistent, or does it need the full corpus or the full transcript to be reproducible or consistent in what it finds?
I'm gonna add, Dr. Olazisi was correct, but I am saying human experts only review random responses, but AI can review 100% given the time differences, efficiency differences between human expert and AI. So we can train AI for 100%, but then we can randomly select some responses for human experts to review. Dr. Tucker here with me, we did that using the X responses, and we have billions of the posts, and at the time, it's just not possible for us to do human experts for all these billions of posts, but AI could do that within a minute. Yeah.
Yeah, I agree with that. I feel like ChatGPT or generative AI definitely can support a lot of coding tasks. Yeah. And for the
there's another question here that is, does reallocating workforce reduce the care quality in well-served areas? So the areas that are already doing well, if you take something away from them, even though you set just the threshold of no more than 20%, does that put their quality of care at risk?
Yeah, I think that's something, to be honest, I want to get more insights from health professionals because I don't know whether that makes sense because as a AI, AI just treats this as a values, as a numbers. So from an AI perspective, yes, we will reduce the care quality. We will reduce. It's not the care quality because we cannot measure the quality, but we can measure how many doctors. We can measure how many resources. Yes.
All right. There's another question here about for the large language model qualitative coding study. How many prompts? How were the prompts structured and iterated?
Yeah, so far you may have heard about the term called prompt engineering. In our study, it's relatively easy because it was relatively simple structure because at that time we were the very first to explore such kind of direction. But now we have more advanced prompt engineering methods which can significantly improve the accuracy. And once you develop one prompt, it's easy to, for instance, you can call its API, you can write the code, you can write the programming scripts to iterate this. Then it will be much faster. But the first prompt would be a bit challenging to develop. Or not challenging, but it takes some time.
Awesome. Great questions and great engagement. Unfortunately, it's 1:00 right now, and I'm a stickler for time. First, I want to say thank you so much again for your presentation to us. It's been a lot of learning information that you provided. Thank you to all of you who have come for this meeting at this point. And again, to reiterate, at INBRE, we're here to serve you. So if you would direct your questions about what to do, how to start, things that you don't know, if we don't know, we'll find someone who knows it and get you on your way. So we will be in contact when we put together the next seminar, and we hope you also attend enthusiastically. We'll let Dr. Kang go back to his cold Sweden and maybe go do some ski and see some places there. But thank you so much, and you all have a wonderful rest of your day and a great weekend. Be safe out there.
Yeah, thank you, Banky. Thank you, everyone.
Bye.
Thank you.
Thank you.